Hi, my name's Professor Tom Wainwright. I'm a physiotherapist and Professor of Orthopaedics at Bournemouth University. Today I'm going to talk about post-operative mobilisation, how soon and how much within enhanced recovery pathways. This is a presentation I gave last autumn at the ERAS Society World Congress, and I'm just revisiting it today and providing an overview of what was covered in that session. So, why is it important to talk about post-operative mobilisation? Well, within the context of enhanced recovery after surgery pathways, it's one of the fundamental interventions, and this is across all the surgical specialties that have employed ERAS protocols. And there's a clear historical rationale and need for early mobilisation, and that's so that patients can avoid the negative consequences of prolonged bed rest. Prolonged bed rest causes major cardiovascular, respiratory, musculoskeletal and neuropsychological changes. Complications often result from these effects of bed rest, especially when ageing has already decreased the reserves in these systems. So it's something that is well known for us to avoid with our patients in hospital, but it's not always easy to achieve. Before we consider that further though, let's just talk about some of the other underlying principles I think it's important to return to. It's important to understand that most of our patients in surgical settings are older patients and older adults undergoing surgery. And we need to understand that ageing impairs the recovery in mechanical muscle function even after 4 days of disuse, and that's shown in this article here, where they took fit older adults and looked at the effect of immobilising their leg within a knee brace for a few days. You can see here the difference between recovery of both the young and old patients on the graph on the right hand side. You can see the pre-level for the young patients in the middle. They then have a look at their recovery and then their post brace function and then their recovery. So they dipped but then they recovered very well. That's different to the older patients who looked at their pre-scores. They then dipped quite significantly after 4 days of immobilisation. And then even with 7 days physio and recovery, they couldn't get up to their pre-levels afterwards. That's really important for us to recognise that older adults will take longer to recover and regain strength that's lost via bed rest. The other important thing that we talk about with early mobilisation is not just getting out of the bed and walking, but the effects of posture, and most notably on things such as post-operative pulmonary function. So avoiding the supine position and getting patients in an upright position is vital for lots of reasons, including orthostatic intolerance and blood pressure related issues, but also pulmonary function and avoidance of post-operative pulmonary complications. And things such as chest infection can be extremely serious in the post-operative patient. So early mobilisation in post-operative care, as we've just started to talk about, is important to help us prevent complications like deep vein thrombosis, pulmonary embolism and pneumonias. It can help with improved circulation and lung function. It can also avoid muscle atrophy and promotion of retaining muscle function and muscle strength. And therefore it will enhance the overall recovery of patients, likely contribute to reducing hospital stay. And there's probably quite significant psychological benefits such as a reduction of anxiety that patients get from being able to walk and move as they normally would do as soon as possible after surgery. So when we talk about early mobilisation in post-operative care, what do we mean? Well, we don't just mean getting out of bed and walking, but we also mean sitting in an upright posture or sitting out of the bed in a chair rather than on the bed, but also standing or marching on the spot, or other exercises that enable us to increase our cardiovascular function of the patients or maintain some degree of muscle strength and the reduction of atrophy. So bed exercises and standing and sitting exercises, another example. However, there are challenges. There's low compliance rates in some ERAS protocols, and across the different surgical specialties it continues to be issues in getting patients to mobilise as soon as they possibly can do, either on the day of surgery or the day after surgery. And there's a range of different things that we explored in this textbook chapter we wrote in the Enhanced Recovery textbook. But barriers include patient-related factors, structural factors, and also cultural factors. And this idea of early mobilisation, we shouldn't think that we can't do it. We need to be thinking that actually in all situations and all contexts, it's possible to mobilise patients early, given that they are medically and surgically safe and stable to do so. A key focus across these different mobilisation strategies is to improve respiratory function, initiate early rehabilitation to prevent muscle atrophy and joint stiffness. In terms of the ICU setting, mobilisation, repositioning and techniques to clear lung secretions are extremely important and something that we should consider. And this can help to reduce the risk of pulmonary complications. We can also initiate rehabilitation such as range of motion exercises to prevent contractures. You can use neuromuscular electrical stimulation to prevent atrophy or improve blood flow for the patient that is bedbound. And then we can start to get the patient sitting, standing and walking. And in this particular setting, HDU and ICU settings, there can be barriers such as the culture, a lack of resources and a need to prioritise these things over more sort of acute medical conditions or needs within that setting. So the solutions include in that sort of sphere increasing leadership and staff training so that staff know the importance and the value of early mobilisation, and then also monitoring and adherence to protocols. So both across the standard ward and ICU setting, it's really important to mobilise patients earlier. And we know that there's improved outcomes if we do mobilise patients earlier. So this is just some examples from across the different surgical specialties. We know in cardiac surgery it can reduce ICU and hospital stays. In colorectal surgery, it can lead to faster recovery of bowel function, fewer complications and reduced length of stay. If we look more generally at abdominal surgery, similar outcomes such as reduced length of stay, reduced complications, reduced infection rates and quicker return to activities. And in conditions such as breast cancer surgery, early physio can also help prevent long-term sequelae such as lymphedema in these types of patients. And again, there's often barriers and compliance due to patient and staff expectations or maybe staff time to facilitate this rehabilitation in the early stages. If we look at orthopaedic surgery and specifically hip and knee replacement, we've got great examples here from how practice has changed from the last 10 to 15 years. We know that early mobilisation reduces length of stay, reduces the risk of things such as DVTs, and does not increase the risk of post-operative complications. So we've seen a massive change in hip and knee replacement over the last 10 years. Patients now going home on the day of surgery. And this early ambulation has been linked to faster recovery. And if done correctly, there's no negative effects or safety concerns. We do have some concerns, though, challenges with certain types of patients, though, such as pain or orthostatic intolerance, where patients have difficulty standing in the early stages due to blood pressure issues. I think what the progress that early mobilisation as part of an enhanced recovery protocol, I think the progress we can see as this kind of key intervention is in this study from the Danish collaborative, where they looked at in-hospital only use of thromboprophylaxis after fast-track hip and knee arthroplasty. Now, most guidelines across the world recommend that we use chemo or pharmacological thromboprophylaxis for at least 10 to 35 days after hip and knee replacement. However, given the low rates that they observed in their collaborative, the authors in this paper questioned the need for this prolonged thromboprophylaxis when the length of stay was less than 5 days. They looked at 90-day incidence of VTE after fast-track hip and knee with in-hospital chemoprophylaxis only. So patients only took the DVT drug up until they were discharged from hospital, and then essentially the intervention was mobilisation and returning to normal activities. And they found the rate to be just 0.4%. Now, against historical data sets, this is an extremely good figure. And so it showed that prolonged thromboprophylaxis may be reserved for patients only that stay longer or have specific high-risk needs. But the authors do highlight, obviously, that there's a need for future studies and more studies to understand this better. But a large study of 17,000 patients, and perhaps is really significant to show how things have changed based on early mobilisation and accelerated recovery pathways after surgery over the last 15 years. So what do the guidelines say if we look at the ERAS Society guidelines across a range of different surgical specialties? Here you can see that we've looked at the guidelines for this table, we've looked at the recommendation on early mobilisation, and then we've seen is there procedure specific evidence or whether translational evidence has been cited. You can see that early mobilisation definitions are slightly different across all of the guidelines. However, they are consistently in all the guidelines, and early mobilisation is a cornerstone of these protocols. If we look at whether there's procedure-specific evidence, there isn't always, and sometimes translational evidence is used. And so what we need to ask here is, why is there a lack of evidence within the literature base looking at early mobilisation? Remember, I'm trying to answer the question in this presentation, how much and how soon should we mobilise our patients? When we looked at a study back in all the studies published looking at early mobilisation, specifically as part of enhanced recovery protocols, we did a review article back, I think it was about 2018, in the European Journal of Physiotherapy. And there was just one physiotherapy study at that stage. And we published a systematic review really with a call to action to say, actually, we need to know more about this area. Because within the guidelines across the specialties, there's things saying such as a patient should stay out for at least 2 hours or no more than 6 hours at certain days post-operatively. But what are we really basing that on? What's the evidence for this? So patients are commonly asked, well, how far should I walk? When can I walk? How often should I walk? So how are we going to answer these questions for our colleagues and also for patients in the future? So we've been recently expanding this review. We've now got an updated review where we found about 11 studies. So over the last few years, there have been some more, but again, a paucity of research. Maybe it's because it's an obvious question and people don't think that research is necessary, in that it's a no-brainer that we should be mobilising patients early. However, what we hear back from audiences such as yourselves at the World ERAS Congress is that people do want some more didactic information about how much patients should mobilise and how often they should do. So more to come on this, and we've got an article on the way with an updated systematic review. So why is it all necessary and why do we get lots of questions? Well, actually, if you're critical and we look at some of the compliance studies within enhanced recovery, we're not actually that good at implementing early mobilisation. We know that it's important, everyone's in agreement of that, and often there's questions about when and how soon we should do it. But actually, if we look at this study from Ulf Gustafsson, then we actually find that we don't hit the high compliance rates of some of the other areas of enhanced recovery pathways as we do for getting patients out of bed on day 0 or out of bed on day 1. So we need to look at the reasons for this, what are the barriers for this, and how can we overcome this? Perhaps going back to Prof. Henrik Kellett's 3 questions: why is the patient still in hospital today, and what is it that we cannot control? So what can we control within these settings that will help us to mobilise our patients on that first day of surgery? Well, in the textbook that we sort of spoke about earlier in this presentation, we highlighted that there was these 3 sort of different factors: physical factors, patient-related factors, and organisational factors. And we created an infographic showing some of the reported barriers and some of the solutions that you could offer in these circumstances. And key part of here is patient and staff expectation of what's going to happen, and then having the structural and cultural support around our wards so that this becomes standard practice and patients can be mobilised. And there are potential solutions which span the pre and also the intra and post-operative phase. So it's not something we just leave till after the surgery, it's something that needs to be educated in our patients beforehand, but we also need to be screening for any potential issues that may delay mobilisation. And then post-operatively, we need to be troubleshooting as soon as we are aware of issues that may limit someone's ability to mobilise and walk after surgery. And as I mentioned a few slides back, these 3 questions Prof. Henrik Kellett asked when he was first implementing fast-track and ERAS protocols. I think the last one is what I want to sort of focus on for the next few slides. What can we control? Well, there are lots of things that we can control that can help us get patients up early after surgery. I think one of the main things is preoperative counselling and education. Patients need to understand the benefit, and they need to understand that's when they will be getting up. If they're expecting to be in bed for a couple of days, they most likely will be in bed for a couple of days. However, if we tell them the benefits for why we're going to get them up, how it's going to be safe to do so, and why it's going to be better for their recovery, then patients are keen to mobilise after surgery. And the sooner we get them walking, the less complications and the easier it is to start their rehabilitation. So some hospitals use detailed daily goals for mobilisation. So these can be on the care record that the staff use, but also you can give it to the patient so they can tick off when they've walked and when they've mobilised each day. Other hospitals have a slightly different scheme where they have like a board that goes next to the patient bed, and there they can move in this case, the magnet when goals are achieved on each day after the operation. The patient diary is also an option here where the booklet is given to the patient and they tick off when they've achieved these things each day. We also need to think about how we can help patients do this. So good walking frames that are easy to use, that are safe and feel safe for the patient to use are obviously crucial, as well as comfortable chairs where patients can raise their legs if required to avoid edema and swelling in cases such as lower limb surgery. And again, these are things that we have control over and we can get our hospitals to change. If it's not suitable for early mobilisation, we need to be thinking about how we can get the right equipment and the right chairs in to make it easier for our patients to mobilise. And of course, just like all ERAS concepts, it's about teamwork. So close collaboration across the professions, notably the nurses and physiotherapists typically, blurring the boundaries between these roles, making it about getting the patient up so that they can start to mobilise and hit their physiotherapy goals, but also understanding it's going to help manage their pain, get their bowels moving in the case of colorectal surgery, get their bodies adjusting to changes in blood pressure after surgery. So it's crucial that we get patients up, not just for physio reasons, but also for a range of nursing reasons as well. And of course, to do this, we also need to make sure we've got the resources available. So staffing is a really important concept within this. This is some data from some years ago in the hospital I worked in the UK, Bournemouth Hospital, when we first implemented enhanced recovery. We changed from a 5-day therapy service to a 7-day therapy service. And what we found was this dramatically changed the excess bed days when patients stayed longer than expected for their case mix. And it also changed this across the days of the week. What you can see here is before enhanced recovery, we have patients staying in the order of hundreds of excess bed days compared to our case mix adjusted. And then what we can see is as we implemented enhanced recovery, length of stay across the different days reduced. What's significant though is we also changed the patterns of discharge, and that was really important because it showed that there was a weekend effect previously within our setting. We found that before the change there were fewest discharges at the weekend, and so consequently there was a backlog of patients to receive physio on a Monday and Tuesday when the staff returned after the weekend. Again, if you notice the change in scale, this is hundreds, and the scale changes slightly down here. But we see here is the number of discharges after the introduction of a 7-day service. We've got a lot more discharges on the weekend days, the Saturday and Sundays, showing that we were able to have a more balanced profile across the week. We had less on a Wednesday because we didn't operate at the weekend, but so that was to be accounted for. So, if we take all of what I've said so far into account, how much and how soon after surgery? Well, I think we can definitely say that mobilisation should start as soon as the patient is stable, typically within 2 to 6 hours post-surgery, or it may be sooner for some patients. All of the ERAS guidelines are clear and they recommend early mobilisation on the day of surgery for most surgeries. How much? Well, the initial goal, I think the goal is to get the patient out of bed, sitting and standing, and then they're going to progress to short assisted walks around the hospital room or hallway. And typically we're looking for 1 to 2 hours out of bed on the first day or as tolerated. Subsequently, we need to increase this to increase the time out of bed and the times that they go from bed to chair and make those transfers, and moving to them to being able to do it independently. However, all of this should be personalised and patient-centred. We need to make sure that we shouldn't just be chasing the goal of getting patients to mobilise. We need to do it as soon as possible, as is right for that particular patient. And this really, I think, gets to the summary of what we want to say, because I don't think there is a one-size-fits-all. I think we need to personalise and tailor our mobilisation strategies to optimise recovery for each individual patient. And that will depend on the type of surgery that they've had, and also the number of different other contributing factors that may affect their ability to mobilise, e.g. their frailty, their age, or any other comorbidities or any other conditions. But what's clear is that we need to mobilise them as soon as possible, and for the vast majority of patients that will be on the day of surgery. If there are reasons we cannot mobilise them, then we should be looking at our pathways to see if that's things that we can control. If it's too much pain, have we instigated our analgesic pathway correctly? If there aren't the staff there, how can we move staffing around to make sure that there are the staff there to mobilise patients as soon as possible? So, in summary, there is no one-size-fits-all, but I think the clear message is we need to mobilise patients as much as they can tolerate or as much as is right for that particular patient as soon as possible after surgery. Thank you for your attention, and if you've got any questions, please do get in touch.